Thank you very much, Nishal sir, for giving such a nice introduction. I would like to thanks all the organizing committee, Dr. Archana madam, Dr. Minal madam, and everything for such a wonderful arrangement. So, as a pediatricians, I like prevention because we are working on the vaccines. So this is the real life case, 10-year-old girl with the type 1 diabetes who diagnosed diabetes at the 7 year of age, had a DKA, was managed over the basal bolus. She has a younger sister who also developed type 1 diabetes at the 6 year of age after just 1 year of her diagnosis. And now the tragedy occurs now. So, youngest sister in the family at the 3 year of age, father and mother and parents are worried about what are the chances to having diabetes, what are the things that we can prevent to type 1 diabetes happening, what to do in this kind of setting. So my whole talk is divided into the 8 fragment with the 8 questions, that what are the available treatment, is that what are the latest research, and from the basic to the advanced. So in type 1 diabetes, insulin is the mainstay of the treatment, but it is just for the symptoms. We are not talking about the cure while we are talking about the insulin, because it doesn't affect the process of the type 1 diabetes. So we need one medicines that cause the prevention or modify the disease prevention in type 1 diabetes. So how are we doing in the type 1 diabetes? So answering my first question, we can have a data of the International Diabetic Federation. In the 2022, 5,30,000 children is newly diagnosed with the type 1 diabetes, and among them, majority of the people were less than 10 years of age. If you see the Indian data, then India has the highest number of the type 1 diabetes, more than the USA, but many of the cases are underreported. What about the life expectancy? When I was in the ISPED Science School in the Italy, that time we have to go on the stage and we have to guess the what is the life expectancy of the our country. Then, except the some country like USA and everything, India has a type 1 diabetic life expectancy is 25 to 40 years. That means they are not living more than the 40 years because of the complication. So in the summary, we require some medication that prevent the type 1 diabetes or modify the type 1 diabetes process. So, second question, what are the need for prevention or disease modifying therapy when we have all the technology available, when we have an insulin pump, when we have a CGMs? Why we are talking about the prevention of the type 1 diabetes? You can see the USA data that has been published in the American Diabetic Association among the 22,000 children. You can see the graph. Here the HB1C, even based of the technology, it is more than 7.5. So if you see the data, then below 70, there are the only 17% of the people are there who has a HB1C less than 7.5. And if you are talking about the adult, then only 21% of the adult are there who are in the control. So we are facing the very bitter truth. What is the truth? That they do have a more chances of the diabetic ketoacidosis and hypoglycemia. Only 80% are under control with the insulin therapy, with the best of the technology that we have, and they do have a frequent hypoglycemic admission. If you are talking about the CV risk, then 2 to 4-fold high risk of the CV risk, even well managed type 1 diabetes. That means we are very far from the glycemic goal. So we need one drug that can prevent or modify the type 1 diabetes progression. Why we talk about the C-peptide level? So previously, if you are talking about the type 1 diabetes prevention, we are not talking about the insulin, we are not talking about the HbA1c, but we are talking about the C-peptide preservation. So this is the world largest trial that you can see of the DCCT trial. Over the years, C-peptide falling down in the type 1 diabetic patient. So they have divided into two groups who are taking the basal bolus and who are taking the mixed start twice a daily insulin. Among them, who has a more C-peptide preservation has a less chance of the diabetic retinopathy, diabetic nephropathy. So C-peptide is an important factor to prevent diabetic complication and the hypoglycemia. So, answering my third question, C-peptide is very important. We have to work on the C-peptide preservation for the prevention, and higher C-peptide can cause lesser hypoglycemia and lesser diabetic complication. So, higher C-peptide is associated with the hypoglycemic prevention, severe risk benefits, and there are the so many long-term benefits are there. Now addressing the four most important question. What are the stages of type 1 diabetes? Just is it a boom disease, or it takes a time to having development? So as everybody know, autoimmunity comes to your body. It particularly target to the beta cell of the pancreas, not all cell of the pancreas, and it can cause a type 1 diabetes. But this process requires minimum few months or years to take having type 1 diabetes. So it is not just a boom process, but it requires few months to year. So that means we have a window of opportunity to intervene, and we can try to having prevention or disease modification. So these are the stages of the type 1 diabetes. In the first stage, you don't have any autoantibody positive, that is a subclinical stage. Second is you have a more than 2 positive autoantibody with no dysglycemia. 100% of them lifetime risk of type 1 diabetes is there. And second stage, there is a more than 2 autoantibodies positive plus dysglycemia. So majority of children doesn't pick up by this point because they don't have any clinical symptoms. They have a dysglycemia. So if you do screening, then you can then you only able to pick up. Otherwise, they are going to miss. And stage 3, you have a full-blown type 1 diabetes happening. So there are the variety of steps. We have to work on this factor. So if you are working before stage 3, then you are working on the prevention. If you are working on the C peptide preservation, then mainly on the preservation, and after that you have to work on the replacement. There is a insulin therapy. So fourth important question, whom to screen? Should we have to screen everybody? So there are the variety of the debate that whom we have to screen. So according to the ADA guideline, there is 3 to 4% risk of type 1 diabetic autoantibody in the family, and only 0.3% risk of multiple autoantibodies in the general population. But if you ask the truth, then in your clinic also you have seen that 80 to 90% doesn't have any family history. So the ADA and ISPED have a different sentence here. ADA asking for the high risk screening, while ISPED is asking about the we have to screen to everybody. And just if you don't give teplizumab, if you don't give any drug modifying therapy, but just by doing the screening, you can prevent the diabetic ketoacidosis happening. So by just doing screening at your home, you can see the data. There is a less than 50% chance of the decay. And what are the strategy for the available for the treatment? So there are the three strategies available. One is for the prevention, preservation, and the replacement. So there are the variety of the research is going on upon the different pathophysiology. The first research has been started with the 1980 with the cyclosporine. But cyclosporine has a majority of the side effect, so that we are not using it. But after 2007, there are the many drugs has been come into the picture which can cause the disease prevention and the modification. But majority of drugs, if you see, they don't have any beneficial ratio. So previously we are talking about the prevention, but there is no benefits in terms of the prevention. But now, according to the latest research, they are more talking about the immunotherapy. So immunotherapy, cytokines based therapy, and the anti-tumor necrosis factor therapies has some proven role for the prevention. If you talk about the etanercept that was given for the 24-week to the children with the type 1 diabetes, you can imagine the C-peptide preservation with this therapy, but there was a variety of the side effect was there. And in the JAK-STAT pathway, there is a one drug which is called as which prevent the hypoglycemia, that is a bericitinib, that can cause the preservation of the C peptide. But again, there is the risk of the adverse effect was there. But now the treatment is there, which is a teplizumab, which is known as a TZILD. which helps us to prevent the type 1 diabetes for minimum 2 years. So it delay the disease progression for the 2 year, and that doesn't having much side effect. So that is a T cell modulator, and you can see in the data in the children's as in the adults there is a preservation of the C peptide level. So this is very promising drug that we have. Uh, Teplizumab is approved, a first drug that is approved by the FDA in the 2022 November, and it can be given to the more than 8 year of age with the stage 2 of the type 1 diabetes, and which preserve insulin secretion. And you can see uh, by just giving the teplizumab, we can reduce 2 to 3 times decrease the rate of the diabetic ketoacidosis. So it is very effective drug. And how to give the teplizumab? You have to give for single dose for 14 days. That is a IV dose, and by that there is a no notice significant difference in the side effect noticed by the placebo group and to the control group. So this is the very good and promising drug that we always dream about.
Manoj,
But main thing is the cost for the teplizumab. But in the future, the cost will be less. Other drug is a rituximab that has a promising result, but we have to find out the more data on the rituximab. And there is a variety of the drug. There is an anti-thymomide globulin therapy, which has a promising result, but we have to look for the more data. Some another cellular drug also has some good result, but we need to see the data. And this is the another promising drug, that is a verapamine, that preserve the beta cell function, that is given by orally. That is an hypertensive drug that can be given orally, that can preserve beta cell function.
Dr.
But
Manoj, 30
for
seconds.
yeah, for giving the type 1 diabetes, we need to have a safety data for this perspective. So my last question, what is the latest research on the type 1 diabetes management? So just by the JDPA 2024 and they have published one nice trial about the GAD antibody activating drug that has a promising result, but we need to look for the phase 3 trial. In the last, in India, we are not talking about the teplizumab because the cost is a issue. So if patients comes to you with a 10-year-old girl with the first time newly diagnosed type 1 diabetes, then what we can do in the India? At least if we don't have the proper preventive medicine, then at that time we can have a better glycemic control. We can introduce diabetic therapy, and by just giving proper diabetic therapy at the first go, we can preserve some beta cell function. So diabetes technology is very important at the initiation, not after 2 years, to preserve beta cell function, to reduce the cardiovascular mortality and reduce the hypoglycemia. And you can see in this data that just by preserving some beta cell function, you can prevent many of the diabetic complication. And this is the last slide of today's, that we do have a new hope in the type 1 diabetes. Previously, we have a cure of type 1 diabetes since 2020 through by Vertex trial. Please note, I have used the word no, cure. Previously, we were not talking about the cure. So after the Vertex result, the cure is possible with the type 1 diabetes. Teplizumab, verapamine, ledixin, GLP-1 receptor analogs, and other therapies that is evolving in this talk. So thank you very much.